Assalamu alaikum. Good afternoon, everyone. Ramadan Kareem, and hope your fasting is going well. My name is Mohammed Aljumaa. I'm a second-year mathematics student, and today we're going to talk about metabolism of phenylalanine and tyrosine. So let's start. First of all, we're going to discuss or give an overview of amino acids. Then we're going to discuss phenylalanine and tyrosine metabolism. Then we're going to talk about some clinical aspects, and finally, we'll have some questions to test your knowledge. So let's start. Let's have an overview of amino acids. So amino acids are mainly the building block of proteins, and we have two main types. The first is essential, and the second is non-essential. So what's the difference between them? The essential, which means that we should obtain them from our diet. Okay. However, the non-essential we can synthesize in our body. But and here's a mnemonic for the essential amino acids. But as you can see here, we have two boxes around the histidine and arginine. Histidine and arginine both are called, they are either, I mean, they are not essential or non-essential. They are both called semi-essential, which means that our body do produce it, do synthesize it, however, not in a sufficient amount. So we need also to take it from the diet. Now, let's talk about the inborn errors of amino acid metabolism. So, the effect in the amino acid metabolic pathway mainly presents at which development stage in newborns. So, how does this go? So, first of all, we have the gene that's responsible for the amino acid synthesis. We'll have mutation in that gene. A mutation in that gene will result in abnormal protein. Having abnormal protein will give us total or partial loss of the enzyme activity or the protein activity. So if we have no function, we'll have accumulation of harmful metabolites that our body don't use. So which will lead to mental retardation. Now, this was a brief overview. Let's talk about the bulk of our lecture, which is phenylalanine and tyrosine metabolism. So this is also a brief overview. So we have phenylalanine and tyrosine are the precursors, or we can get from them neurotransmitters like dopamine, norepinephrine, and epinephrine. The metabolism of phenylalanine and tyrosine requires enzymes and some cofactors that we're going to see throughout the pathways. And any defect in the metabolic pathway will result in a disorder. So let's talk a bit about this. So first of all, we have phenylalanine. Phenylalanine will give us tyrosine. Tyrosine will give us L-DOPA, and L-DOPA will give us dopamine. Dopamine will give us norepinephrine, and finally, norepinephrine will give us epinephrine. So how does this work? Let's see. So for phenylalanine to give us tyrosine, we'll need phenylalanine hydroxylase and BH4 or tetrahydrobiopterin. Now, phenylalanine will give us tyrosine. Tyrosine, to give us L-DOPA, we need tyrosine hydroxylase and BH4. Then, as you mentioned, L-DOPA give us dopamine. How? By dopa decarboxylase and vitamin B6. Now, if we want to inhibit the conversion of L-DOPA to dopamine, we use a drug called carbidopa. Then we have dopamine to norepinephrine. What do we use in dopamine to norepinephrine? We use dopamine beta hydroxylase and vitamin C. Now we have norepinephrine to epinephrine. What do we use in it? We use in it phenylphenolamine and methyltransferase, or and SAM or S-adenosylmethionine. Now, how do we get the BH4 or tetrahydrobiopterin? Simply, we have BH2 or dihydrobiopterin and NADH. We add them together along with an enzyme called dihydropteridine reductase, giving us BH4 and NAD+. So, do you guys have any question till now, or is there anything difficult? Okay, so let's continue. Okay. Now, how do we get the SAM or S-adenosylmethionine? So, as you mentioned, we have norepinephrine to epinephrine, and we require phenylphenolamine and methyltransferase and SAM. What is SAM? It's mainly methionine and ATP or adenosine. So the metabolism of SAM, as it's being metabolized from norepinephrine to epinephrine, will give us adenosine and homocysteine. Now we need more SAM to convert norepinephrine to epinephrine. So the homocysteine, we add to it N5 methyl tetrahydrofolate along with vitamin B12 to give us methionine and tetrahydrofolate. And this methionine is used again with adenosine to give us sound. Now, let's talk about the tyrosine derivatives. From the tyrosine, we can have thyroxine or melanin. So how do we have the thyroxine? Simply by adding iodine, we'll have thyroxine. What is melanin? It's mainly a pigment in skin, hair, and eyes, and it's synthesized mainly by melanocytes. So how does this goes? So we have tyrosine. From tyrosine, we have tyrosinase, which will give us dopaquinone, and then we have melanin. How do we break down the tyrosine? We have tyrosine, HDA or homogenetic acid. Then we have fumarate and acetoacetate. So from tyrosine to HGA, we have some metabolic reactions that you are not required to know. Then from HGA to fumarate and acetate, we use an enzyme called homogenetic acid oxidase. And it's important clinically, and we'll discuss it, inshallah, in the few slides. Now, catecholamine breakdown. So you should know that the dopamine, norepinephrine, and epinephrine are the derivatives of phenylalanine and tyrosine. They are called catecholamine. And the breakdown, we break them down by two enzymes. The first is MAO or monoamine oxidase. The second is COMT or catechol O methyltransferase. Now, the dopamine, and we'll have two products. The dopamine will give us one product, which is the homovanillic acid, okay, and the norepinephrine and epinephrine will give us vanillyl mandelic acid. Yeah, and also you should know that the monoamine oxidase inhibitors, they are used to treat depression. Why? Because having high level of dopamine, norepinephrine, and serotonin helps us in treating depression. Now we have norepinephrine and epinephrine. Norepinephrine and epinephrine breakdown, as you mentioned, that we have catechol-O-methyltransferase and monoamine oxidase. But you should pay attention that when we break down dopamine, we're having the homovanillic acid either by uh, by the monoamine oxidase or methyltransferase. We'll have the catechol-O-methyltransferase. We'll have the same pathway. However, if we for the norepinephrine, if we start with catechol-O-methyltransferase, we'll have normetanephrine. However, for the epinephrine, if we used catechol-O methyltransferase first, we'll have metanephrine. And then both by monoamine oxidase and monoamine oxidase will have vanillin mandelic. But norepinephrine and epinephrine, if we start by breaking down by the monoamine oxidase, both will give us dihydroxymandelic acid. And the dihydroxymandelic acid by the catechol-O methyltransferase will give us vanillyl mandelic acid. So the final product will be vanillyl mandelic acid. Now, let's come to the clinical aspect of the metabolism. So first of all, we're going to start with phenylketonuria. What is phenylketonuria? It's mainly a defect in the enzyme, which is phenylalanine hydroxylase and BH4. So where did we use the phenylalanine hydroxylase? As you can see here, and that's we use it in the phenylalanine to tyrosine. Okay, so yeah, either pH defect or BH4. So how can we know that this patient have phenylketonuria? We'll have some symptoms like CNS symptoms, including mental retardation, seizures or tremors which like involuntary movements. We'll have musty smell in breath, sweat, and urine. Uh, Also, we'll have pale skin, fair hair, and blue eyes since as you mentioned that we have phenylalanine, tyrosine, and tyrosine is metabolized into or can give a melanin. So since we don't have tyrosine, we won't have melanin, so we will have no pigmentation. And also we'll have presence of phenylketone in the urine. Now, how can we treat phenylketonuria? It's mainly restrict phenylalanine. Why? Because as you mentioned that we have phenylalanine hydroxylase, so the phenylalanine isn't going to become tyrosine, so we'll have accumulation of phenylalanine, so we will restrict it. We will also restrict aspartame. Why? Because aspartame it's made of aspartate and phenylalanine, so as you mentioned we don't need phenylalanine. We'll take tyrosine because we have deficiency in tyrosine, and we will monitor the levels of phenylalanine. Finally, if we have defect in BH4, we'll give we'll give dopamine precursor L-DOPA and serotonin precursor, which is 5-hydroxytryptophan. Why? Because the BH4 is required to give to have dopamine and serotonin. And also, you should know that we do screening for phenylketonuria in newborns mainly after 2-3 days, once they are born. Now, the deficiency in pH4 will lead to elevated phenylalanine, decreased epinephrine, norepinephrine, dopamine, and serotonin. And you should know that the low dopamine, which will give us high prolactin. So, do you have any questions about the phenylketonuria? Great. Let's continue. Now, we'll talk about a nice disease, the Parkinson's disease. It's mainly caused by what it is Parkinson's disease. It's a neurodegenerative movement disorder that's caused by low dopamine or insufficient dopamine due to loss of dopamine producing cells in the brain. So how can we know that a person have a Parkinson? It's not found in the slides, but it's mainly by a symptom known as hypokinesia, or they have difficulty in initiating movements. It also includes shuffling steps, masked face, and asymmetric resting tremor. And they have a tremor which is mainly called, you don't need to know this, it's pill rolling tremor, as if they're rolling a pill in their hand. How can we treat Parkinson's disease? It's simply administer L-DOPA or carbidopa. So, guys, since we have a deficiency in dopamine, so why don't we give dopamine directly and that's it? What do you think? Exactly. So it won't cross the blood-brain barrier. So we'll give L-DOPA or carbidopa. So why should we give carbidopa? Because the carbidopa will prevent the L-DOPA to be converted to dopamine, and as you mentioned, we need L-DOPA. So let's move to our next clinical aspect, which is oculocutaneous albinism. So as you mentioned, guys, that the tyrosine give us melanin. So what is the cause of oculocutaneous albinism? It's either deficiency in tyrosinase or tyrosine transporter. And we have two types of albinism, as you can see, type 1 and type 2. So if we don't have melanin, and as you said, melanin is important for pigment in skin, hair, and eye. So we'll have pale skin, blonde hair, and blue eyes. And they have high risk of sunburn and skin cancer. Now let's go to Alkaptonuria. So what is Alkaptonuria? It's an autosomal recessive deficiency in homogenetic acid oxidase. Where do we use this? In tyrosine. Let's check it here. Yeah. Look, we use the HAO in the homogenetic acid in tyrosine metabolism. So yeah, here we go. So it's autosomal recessive deficiency, which means that if you have one allele of the disease, you won't have the disease, you may be a carrier. However, you require two alleles to have the disease, two alleles that have disease, so you can have the symptoms of the disease. How can we know that a patient is having alkaptonuria? Simply by having dark pigmentation. We have ochronosis, which is mainly pigmentation that is deposited in connective tissue. As you can see here in the first picture, we have some pigmentation around the mouth. We have dark urine when left standing. So they make, for example, an urine test, and you wait for 2 hours. It will appear like this, black. You'll have arthritis and finally calcification intervertebral discs. So as you can see here, we have here the vertebra, and between the vertebra, we have a calcification, which is this white ball. Okay. Then we have diagnosis and treatment. How can we diagnose alkaptonuria? Simply by elevation of homogenetic acid in urine or plasma, since we're having deficiency in the HAO. How can we treat it? By tyrosine and phenylalanine, because as you mentioned that we need it's the metabolism of tyrosine. So tyrosine isn't being metabolized, so we should prevent tyrosine and what gives us tyrosine, which is the phenylalanine. Now let's go to our last clinical aspect, which is pheochromocytoma. Pheochromocytoma, it's mainly excessive tumor of adrenal gland due to excessive catecholamines, and it's diagnosed by metanephrine and normetanephrine, high metanephrine and normetanephrines, and 24-hour urinary collection. So why will we have high metanephrine and high normetanephrine? Because as you mentioned, we have high catecholamines, and the metabolism of catecholamine will give us metanephrine and motanephrine throughout the metabolism, so they'll be high. And do you have any question, guys, grounding any clinical aspect or any question, or all clear? Great. طيب. Now, let's test your knowledge a bit. So we'll start with the first question. So I'll give you 1 minute. Try to solve it. It doesn't need 1 minute, بس يعني. Exactly. D. Why? Because we are having phenylketonuria, which means that we either having defect in the phenylalanine hydroxylase or the BH4. So we're not having phenylalanine to tyrosine, and we have deficiency in tyrosine, so we'll give tyrosine. Exactly. Let's have our second question, which is, yalla, try to solve it. Yeah, sure, I'll read it. But during a clinical study, an investigator examines the effects of monoamine oxidase inhibitors to treat certain types of major depressive and phobic and anxiety disorders. The concentration of which of the following compounds is most likely to be increased as a result of this treatment? So, guys, here he's saying that we're using the monoamine oxidase inhibitors, and we did mention this in the slides. Like why do we use it mainly? Exactly, epinephrine to treat depression. Now, let's have our last question. طيب. A 3-month-old infant experienced several severe seizures and was brought to the doctor for testing. The test results showed hyperphenylalaninemia, and the doctor diagnosed PKU or phenylketonuria as the likely disease causing the seizures. The infant was placed on a low phenylalanine diet but developed progressive neurological symptoms and died 6 months later. A defect in which of the following enzymes would best explain the observations and outcomes in this case? So, what do you think, guys? So, why A and why B? Like, what's the difference, or what's a clue in the question that can tell us, it is dihydropteridine or phenylalanine hydroxylase? Uh, it's not phenylalanine. Here the question is saying that he is having phenylketonuria, تمام? And we said that we have two causes that can get us phenylketonuria, a defect in phenylalanine hydroxylase and BH4. Okay, and here he restricted the phenylalanine. Okay, but the result was he died. So exactly, exactly as you guys are saying. So it's A, dihydropteridine reductase. So this is an important concept, guys. You should differentiate between the dihydropteridine reductase or phenylalanine hydroxylase because both will give us phenylketonuria. تمام. Thus, when we like a point to differentiate between them, that when you give a low diet phenylalanine and you have bad prognosis, or the patient won't benefit from it, so it's dihydropteridine reductase. If you give a low phenylalanine diet and the patient was treated or benefit after it, so we'll have phenylalanine hydroxylase. Do you have any question, guys? Is everything clear? Okay, I think we're done.